introduction to those outside of UCSF. Thanks for joining us. This is our Global Child Health Lecture Series. I'm Teresa Courts, and Sohail Sud and I are the co-directors of the Global Health Scholars Pathway here at UCSF, and we're really excited to host this annual lecture series. And today I get to introduce Dr. Matt Wiens. There we go. See, I need to practice it. Sorry. Who is joining us from the University of British Columbia. I've had the good fortune of being able to work with Matt on several different projects. He's really a leader in the field of pediatric post-discharge mortality as well as sepsis care. He works primarily in East Africa and is has his PhD in pharmacy medicine. So I think it's really interesting for the trainees on the call as we talk about kind of different routes and career paths in medicine. To hear yours as well, Matt, and to see the amazing work that you're doing in epidemiologic research across the world. So with that, I'll let you take it from here.
Excellent. Thank you, Teresa. I assume you can all see my screen still. It's a pleasure to be here today to chat with you a little bit about some of the work that we've been doing in Uganda over the last 12, 13 years. It's going to be sort of like a bird's eye view of some of the main features of what we've been looking at, and hopefully we can have a productive conversation, and hopefully I'll take about 45 minutes, and then we can talk a bit after that if there's any questions or comments around some of the work that we're doing. So I have no disclosures. So this is sort of the overview of what we're talking about today. First, we'll chat a little bit about sort of sepsis and its magnitude globally. We'll talk a little bit about the pediatric post-discharge mortality issues in general in low-income country settings, followed by some of the particular stuff that we've been working on in Uganda related to the epidemiology of post-discharge mortality in children. Then we'll sort of move into sort of a prediction modeling and why this is important and what we're doing around predicting mortality or vulnerability. And finally, and finally, we'll talk about a bit about some of the solutions that we're trying to develop to hopefully improve some of these issues. So first, sepsis. So what is sepsis? Obviously, sepsis is a disease that occurs from a severe infection that causes some perturbation of organ function. So here we see sort of the triad of myocardial dysfunction, hematologic dysfunction, and endothelial dysfunction, ultimately leading to failure to perfuse vital organs. And this really is the common pathway to death for most infections, regardless of their etiology. So there's a list of some obvious ones there. Obviously, COVID-19 is the most recent addition to the list of causes of sepsis. And whether this is caused by bacteria, virus, parasite, etc., it's all ultimately sepsis. So a few years back, the Institute for Health Metrics and Evaluation published the first attempt to put sepsis into a global perspective. In this study, they sought to estimate the incidence and the mortality of sepsis worldwide. And what they found was that sepsis was actually quite common. They were, in 2017, nearly 50 million cases, which represented 11 million deaths. Of these, over half the cases and about a third of the deaths were in children. In total, sepsis deaths were accounted for about 20% of all deaths worldwide. It's a very common cause of death. So looking at the contribution of sepsis according to different underlying causes and according to age, you can see that sepsis is really obviously important, especially among children and elderly. So the Global Sepsis Alliance has recognized the massive burden of sepsis for some time, but has been instrumental in lobbying efforts to highlight this to the various world bodies and other governing organizations. And they paid off really in 2017 when the World Health Assembly unanimously adopted a resolution that declared sepsis a global health priority. So in this resolution, there was a focus to improve prevention, diagnosis, and management of sepsis. And this disease, which was previously poorly recognized and understood within the spheres of both the public and policymakers, is now increasingly recognized as a major public health threat. So when considering the preventable causes of sepsis, we need to look at where these deaths primarily occur, which leads me to issues of inequity and why really we need to focus on low income settings. So here in the first image, we see that wealth is primarily concentrated in the global north. And if we contrast this to where the deaths are, in this case, under 5 deaths, we see that in resource-constrained settings, such as those in Africa and parts of Asia, so this is where most of the deaths occur. So likewise, the burden of sepsis is also concentrated in these regions, which really makes sepsis as much of an economic and social disease as it is an infectious disease. And I think that addressing issues related to sepsis is therefore very broad and very complex. And for those of you who don't know about these world mapper images, essentially what they do here is they look at they reshape the size of the country according to the particular metric that's being measured. So in this case, it shrinks when there's lower deaths and expands when there's higher deaths. So the solutions that work well in a resource limited setting don't necessarily work well, or perhaps not likely to work well in a resource in a high resource setting, and vice versa. So here we can see a figure of the percentage of global workforce, which is on the x-axis, and the global burden of disease on the y-axis. And you can see that as the workforce increases, the burden of disease decreases, which basically shows that where we have lots of resources to hire health workers, there's actually a lower relative proportion of disease. So we can't just take what works in our high income settings and apply that to, for example, a place like Uganda, because we just don't have the resources to make that kind of an innovation work, so we need to be innovative. So a little bit about post-discharge mortality in low-income country settings. So I wanted to begin with sort of this slide of a journey of a mother and child. So here we can see that there are many areas where delays or barriers occur that lead to poor outcomes. Oftentimes there's delays in illness recognition or in recognizing the need to seek care, which is sort of the first image. Second, there's often delays in actually seeking care among those who actually want to seek care due to various complexities. This can include things like funding for transportation, poor transportation infrastructure, poor roads, difficult terrain, etc., geographic barriers. And even if a facility is reached, for example, there's often delays in receiving care. So issues around triage and prioritization. And finally, when they do receive care, there may be a plethora of other barriers to receiving high quality care. So for example, congestion, few healthcare workers, complex social dynamics, etc. However, even when care is received, this is not where things end. Following discharge, this whole cycle, in a sense, repeats itself, but in a magnified way. It's now well known that generally, as many or more children die after discharge than during the initial hospitalization. And this is really the area that I'm focusing on. Really, how do we successfully transition children from hospital to home? So we've just been working on a meta-analysis in the last few months, around summarizing the research around post-discharge mortality. It's sort of an update to some prior work that we'd already done. And we've been able to identify quite a number of studies recently that have looked at post-discharge mortality, and we've sort of pooled them according to sort of the disease subgroup of relevance. So here we have 5 different disease subgroups: malnutrition, anemia, all admissions, diarrhea, malaria, about 20 studies, just over perhaps. And you can see here that post-discharge mortality varies according to disease subgroups. So in kids with malnutrition, upwards of 8–9% of children will die during the post-discharge period. This is 6-month post-discharge mortality, by the way. Anemia, it's around 5–6%. All admissions, just over 4%. Diarrheal illness, 3%. Malaria, about 2.5%. So this is obviously a significant number of kids dying during the post-discharge period when we pool the existing studies. In terms of the overall burden compared to overall mortality, we can see here this is the pooled proportion of deaths that occur in hospital versus post-discharge at 6 months. So in general, post-discharge deaths make up approximately as many as in-hospital deaths. In different groups, different proportions. So for kids with anemia, these kids remain very vulnerable during the post-discharge period, and this accounts for actually the majority of the total deaths. For malaria, a little bit less so. But in general, we can say that post-discharge mortality accounts for about as many deaths as in hospital mortality. So what are we doing about this? So sepsis is sort of the underlying sort of rubric here, severe illness, which is often infectious disease related. If we look at current guidelines around sepsis, there are really no mentions of it. So if we look at the Surviving Sepsis campaign, which is really focused on sort of a high-income country setting, there's no mentions of post-discharge mortality or vulnerability. So moving to sort of the low resource settings, again, we see here a resource of almost 200 pages, 10 chapters around sepsis management in resource limited settings, not a single mention of post-discharge mortality or post-discharge vulnerability. Specifically, guidelines for India for addressing sepsis, nothing around post-discharge mortality, looking at the WHO, guidelines here for for management of critically ill children, no mentions for post-discharge vulnerability, post-discharge mortality, post-discharge outcomes, 88 pages. So what do we see here? Well, we see here an opportunity. So post-discharge care is an opportunity waiting to be addressed. And this is really what we're trying to do with our work in Uganda. So now let's talk a little bit about some of the stuff that we're doing in Uganda. So we have developed what we call the Smart Discharges program. Really there are a few aims that we seek to achieve here. So we really have three main aims. So firstly, we want to better understand the epidemiology of pediatric post-discharge mortality in the context of sepsis or severe infection. So what is actually happening here from an epidemiologic perspective? Second, we want to build predictive models that can identify children who are at high risk of mortality. So if we have models that can predict risk, then hopefully we can identify the children who are most in need of additional care. And using this sort of child-centered approach, we can actually build health system efficiencies and improve outcomes at the same time. And finally, we seek to develop innovative programs that can actually improve the resilience of children during the post-discharge period through improvements in the health system. This is a collaboration. We have been working, again, as I mentioned, for about 12 years in Uganda, and there's several organizations that are involved in this. So first of all, I'm involved with the Center for International Child Health at the University of British Columbia, and obviously we're a big part of this. We have been collaborating with the Umbrara University of Science and Technology since about 2011 on doing some of the basic epidemiological work around this, which is where one of our main sites is, the hospital there. We had early collaborations with the Uganda Ministry of Health. It's very important from our perspective to engage the key stakeholders early on. I think one of the big issues around solutions that are being developed for problems that exist is that they're often not developed in a way that are easily or even generally scalable. And this is why often we see studies that show potential benefits that are never transitioned to actual changes in care. So we wanted to work with the Ministry of Health early on to ensure that whatever solutions we came up with were actually implementable. And finally, we've been working with an NGO in Uganda called Walimu. This is an NGO focused on working with the Ministry of Health primarily around training healthcare workers, improving healthcare capacity, and conducting research. So they are sort of our implementation partner through whom we sort of do a lot of our implementation related work. So we've done several different studies, and I'm not going to highlight really very many of them at all, but I wanted to highlight this more recent study that we have been doing and have now finished doing, which is sort of further diving into sort of the epidemiology of post-discharge mortality. So in this study, we enrolled children. It's sort of a combination of two cohorts. So essentially, we enrolled children who were admitted and who had a proven or suspected infection. And this is sort of our loose definition of sepsis. And we've previously shown that this definition actually captures, that 90% of the children who meet these criteria actually meet the International Pediatric Consensus Conference definition of sepsis. So it is primarily a septic cohort. So admission with suspected or proven infection. And then we look at these children for their admission and for 6 months after discharge. So what we found when we enrolled about 6,500 kids is that the post-discharge mortality was higher than the in-hospital mortality. And we had very few losses to follow up. Overall, we found about 390 deaths during the post-discharge period among the approximately 6,000 kids who were discharged. So here we can see the impact of age on mortality during the post-discharge period. Children who are younger obviously have a higher risk of mortality during that period. Few other pertinent things to point out. Malnutrition is obviously extremely important in terms of robustness during the post-discharge period. Children who had a weight per Z score of less than -3 had a much higher risk of mortality. I think the hazard ratio is somewhere around 5 compared to kids who did not have overt malnutrition. So obviously we collected a lot of risk factor information. We have probably about 200 variables. Obviously this is not the intent to go through every one of the different risk factors, but just a few highlights here. So I've already mentioned that malnutrition is important. Here we have mid-upper arm circumference as a measure and producing very high hazard ratio. If the child was referred, they have a higher chance of having a poor post-discharge outcome. In general, what we see is that children who are more acutely ill at admission have a higher probability of death if they survive during the post-discharge period. So markers of acuity generally are also markers of vulnerability during the post-discharge period. So here you can see a variety of markers. So hypoxemia, respiratory distress, CAP refill greater than 3 seconds, abnormal coma score. Anemia is also quite a common risk factor. So hemoglobin less than 7 produced a high hazard ratio as well. And we saw some social variables as well. One of them is maternal education. So we see here that as moms had more education, subsequently, these represented families where the children had a higher probability of success, survival during the post-discharge period. And obviously, this could be related to things beyond just the education itself, but obviously the social context around mothers who were educated is probably less barriers to a variety of things that are risk factors for death. So where are children dying? So one, I think, very interesting thing that we saw, and that others have seen as well, is that when deaths do occur, they more often than not do not occur during a subsequent readmission. So half of the deaths that we observed occurred at home, 16% during a health-seeking event, so on the way to seeking care, and only about a third died during a subsequent readmission. So essentially what we're seeing here is that children who should not be dying probably at all generally are dying without any care whatsoever. So these are kids who have previously seen care. So these are kids who have obviously sought care at the hospital with their parents, but then who subsequently, when they get ill again, for one reason or another, do not make it back to the hospital. This is, I think, again, reflects the opportunity that we have to hopefully improve health-seeking patterns in vulnerable children.
Matt, I'm so sorry to interrupt. Do you mind if I just ask a question? Where does like the primary care or the clinic fall within this chart? Would you consider it as part of the hospital?
Sorry, I'm not getting your question. What
Oh,
do you mean?
I mean, my understanding is in many places, the quote unquote hospital can be quite far from their home, right?
Yes.
And so oftentimes there will be a clinic or some type of outpatient facility where some care is sought before a referral or transfer is made. And just curious if in this course, if that's somewhere along the spectrum too, of where children end up dying.
Yeah, so no, so we aren't specifying whether this hospital is a discharging hospital or not. We're specifying any facility where there's an admission. So is that child admitted at any facility, right? So whether it's a hospital where they're discharged from or a health center nearby that can potentially admit, this is just, so these kids are literally dying at their house. We do also have information on did they have prior health seeking during that time? But for example, some kids who die at home may have being readmitted, let's say on day 5 post-discharge, discharged on day 9, and then died on day 20. So it doesn't mean that they didn't have any health seeking between discharge and death, but when they died, they were dying at home. And obviously these kids are generally not palliative. This is not an issue that we would be normally seeing in this context. These are kids who just had pneumonia. These kids had, the common infectious illnesses, but their death occurred at home. Does that answer your question?
I think it's about the primary care, right? Like, does health seeking behavior also include if they went to, say, their outpatient pediatrician or an outpatient health center?
But this chart doesn't address health seeking other than the fact that, well, half of them did seek care because they were either hospitalized or they were attempting to get care. But the other half, while they may have sought care prior to death, they died in a context where they were not currently seeking any care because they died at home.
Yeah, I think the question was more, correct me if I'm wrong, Sohail, if they died at their primary care pediatrician, given that there's more outpatient centers, if that's accounted for in this chart, like, does that get considered as a hospital because it's care, but it's not a place that would have admission capacity?
Yeah, so if they were at, let's say they have these sort of like informal clinics run by sort of nursing assistants or even self-declared, health workers in the back of their house, perhaps that would be I would consider that we would have labeled that as a facility death, even if it's an informal facility. So these ones literally died. I mean, for sure, they could have had some traditional caregiver coming to their house to provide care at their own home. That's potentially possible. Yes, we would have counted that as an at-home death. But generally speaking, that's not the case. We did verbal autopsies on all these kids, and very rarely was there any indication of any sort of intervention at home, if that makes any sense.
Great, thank you. That does address my question.
Yeah, I mean, I think that a key point here is that children should never die at home unless there's, circumstances such as palliative care. And I think this gets to the point that we need to sort of ultimately address issues around health seeking, because just because someone has sought care previously doesn't mean that they're going to seek care subsequently. And it's not like children are either likely to seek care or not. There's obviously complex things that are occurring here, and not least of which are financial complexities around the need. We've seen even children who we did a study recently looking at the out-of-pocket costs when children are admitted at public facilities that are fully paid for by the government, things, for example, such as food during admission is not covered, and of course there's activities at home that are then not being completed, such as taking care of other kids. And we see something like, I think 20% of families had to sell assets just to pay for those basic costs. And oftentimes there are catastrophic financial expenses related to just simple admissions for a few days for many individuals, including especially those who live in more rural environments. And we saw also that children coming from more rural environments have a higher probability of having poor outcomes after discharge as well. So there's a lot of social and demographic issues that play into some of what we're seeing here. So prediction models. So why develop a prediction model? So I think there's a few different reasons why. So first of all, this allows us to risk calculate based on multiple risk factors at once. So I showed you some of those hazard curves before based on mid-upper arm circumference or weight for age Z-score or age or whatever. And if we're doing a proper risk score, we take into account all the key predictors at the same time to give us a better understanding of who's at risk and who's not at risk. And so it allows us to divide our population to high and low risk or high, moderate, and low risk groups much easier. Secondly, it's definitely it's more data driven. So a lot of the recommendations on sort of like risk factor related care is often not data driven. And I think it's really important that when we make recommendations that it is as much as it is possible that it's driven by good, high quality evidence. And I think that this is really the key to a child-centered care. So we talk about precision medicine this is sort of precision public health. And I think that centering the care around an individual's individual risk factors is obviously a better way to do things, because you actually improve efficiency as well. So for example, if we said, oh, everyone's at high risk of dying because it's common, therefore we need to follow everybody up, that creates an inefficiency, because there are some kids who will do very, very well, who should perhaps not be followed up given the limited resources that exist. So especially in resource limited settings, the idea of a personalized approach is actually probably more attractive. And finally, I think it can actually help motivate caregivers. So if you can tell a mother that her child has a particular degree of risk based on certain easily identifiable risk factors, such as your child has anemia, they have malnutrition, and these things are contributing to a higher risk, that can probably convince a parent more easily than saying everybody gets this, everybody gets that. So I think it helps motivate the caregiver to take a responsibility for individual risk factor or risk factors that can help hopefully improve their health seeking and care during the post-discharge period. So we used all of this prior data that I showed you to develop clinical prediction models. So we used the prior data and then also some data from a few years back that we collected to build models. So we built models separately for children who were under 6 months and over 6 months. And the idea was we wanted to build models that had a reasonably high sensitivity. So we aimed at building models that had sensitivity of at least 80%, so capturing 80% of all the deaths that occur within 6 months of discharge. And using this, it divides children into about a 45% children being high risk and 55% of children being low risk. Actually, for the under 6-month-old model, we actually had two cutoffs. So we had a moderate, high, and very high risk. This is a picture based on a single cutoff. So the multiple cutoff model that we actually ended up using was approximately, I think, 30% were moderate risk. I think 40% were high risk and 20% were very high risk, something like that. But essentially what that does is it allows us to have sort of a risk-based approach to what do you do based on individual risk factors. For our older children, we had a single risk cutoff, low and high, and that divided kids into about a 35-40% high risk and 60% low risk. So what are the kind of risk factors that come into our model? So our intent was to have models that were reasonably parsimonious, so simple, using risk factors that were easily collected and probably already part of routine data collection. We also built a series of models. So we didn't just do one model for each. We built about 3 or 4 models for the older children, for example, so that depending on which variables were available, multiple models could be used. This is a very common practice. So for example, if you're using Facebook or Twitter or Spotify, based on the data that you input, a model would be produced to make a recommendation. So we've done the same thing here. So we've built models with many variables and with fewer variables, and depending on what is available, it will still be able to give you a risk prediction. And the performance, although it's a bit better with more variables, you don't lose that much by having fewer variables. So these are the kind of variables that we included. So primarily, anthropometry was a big part of those variables. So MUAC, weight for age, Z-score. Severity indicators were also really important for the under 6-month-old children, while for the over 6-month-old children, we had severity indicators along with some social factors that predicted risk. So building solutions for post-discharge mortality. This is the last section that I'll talk about today. Time is still doing okay here. So what is a smart discharge? So we call a smart discharge something that has sort of 3 different aspects. So the first piece is around risk stratification. So at the point of admission, and I should mention this, all of the risk factors are collected at admission. And the reason that we've done this is because we want to have discharge planning occur when a child is admitted. And we want the information necessary to understand risk to be present as early as possible so that a child can enter sort of a pathway of discharge planning based on their degree of risk during the post-discharge period. So first thing we do is children are screened at admission. Question really is, does the child have known vulnerabilities that suggest the need for intensive follow-up? The second piece really is around educational counseling. So it's really important that we this is important for both the health workers as well as the parents, that we recognize that discharge does not equal cure. And I think that's oftentimes the case when parents feel, that the child is being, if their child has been discharged, they talk about them having been cured. And that's a sort of a misnomer. And I think the idea is that, recovery takes time. And discharge is one stage in that process, but care must continue at home. Recognition of danger signs, this is important for parents. Post-discharge care practices. So what do we do during the post-discharge care period? And that obviously depends, at least in part, upon sort of key risk factors such as malnutrition or anemia, for example. Post-discharge follow-up. So for children who are at high risk, we really want to encourage routine follow-up within the community. So not necessarily coming back to the discharging facility, because oftentimes there's expenses associated with that, as well as a burden on the facility itself to see a large number of children. But in the community, we have community health workers, or we have lower level health centers that could do potential follow-up to look for example, danger signs or needs that might require a referral to a higher level facility. And then at the point of discharge, we want to educate parents around the expected course of recovery and the timeline for that, provide follow-up guidance, and of course review the counseling that has been sort of done during the admission process or during the period of admission. So in a schematic, this is what we sort of see. So when a child is admitted, they are screened. They provide counseling is provided during the admission itself, as well as at discharge, and then follow up. And we've done some preliminary work on this. We did a sort of a pilot study about 5 years ago, which showed improvements in follow-up, higher readmission. This really addresses the at-home death issue. So we want to see more kids readmitted because those kids who are dying at home should be readmitted. And we saw lower mortality. It wasn't statistically significant because it was a smaller study, but then we've sort of done an interim analysis of our current ongoing study. So we're doing a current study of about another 6,000 kids, and we're seeing in our interim analysis, we're seeing lower mortality. And hopefully by the time we do the final analysis, we'll see that achieving a statistical significance. In the meantime, we're working with a lot of partners. So first of all, we've done our own building our own apps. So, like I mentioned before, so we are focused both on sort of epidemiology, we're focused on predictive modeling, as well as on innovative solutions. So part of that is understanding how do we ensure that health workers can actually implement a risk tool and conduct improved care at discharge and after discharge. So we developed an app that can allow health workers to quickly identify the at-risk child, recognizing that an app is not necessarily a good solution, but it's a temporary solution. We're also working with others. So we're working with a company in Uganda called iStreams. They developed a product called Streamline, which is a digital electronic health platform. And then this is being rolled out. So they have quite a bit of a reasonable market share in Uganda. They're working with, I think 30 or 40 facilities now who have implemented this EMR system, and several facilities now have embedded in them a discharge risk screening tool based on just basic admission parameters. So we feel like this is probably a more sustainable and scalable way of ensuring that risk is understood by health workers. Obviously, we can't just give facilities an app or a program. It has to be paired with proper intervention and training. So we've had a series of stakeholders meetings with various interest groups, especially the Ministry of Health in Uganda, who we've been working with, as I mentioned, for the last 7 or 8 years, to help develop strategies for providing tools to help facilities improve their discharge process. So among other things, we've been able to work with the ministry to develop a variety of counseling cards, which are used by nurses to educate families around discharge care practices. This is for health workers. We have also one for the community health workers. So we've trained community health workers around the provision of post-discharge care in various districts in Uganda. We've also worked with Ministry of Health to develop these mothers counseling cards, which are given to mothers We've also updated the mother-child health passport, which maybe you guys have seen as well. In various countries, we have sections in there around post-discharge care. We've worked with the ministry to develop sort of a quality improvement program. So what we have is we have these facility scans, which sort of assess discharge practices. We've developed a 3-day discharge training program, which integrates sort of smart discharge's approach to care with just general discharge guidance and practices based on other resources as well, including IMCI, and a monitoring and evaluation program. So this is in conjunction with Walimu, our partner, who has been doing a lot of implementation work around improving discharge care. With this, we have worked at 16 different facilities to try to improve or implement a discharge training program. We've trained about 170 health workers around discharge care, 900 community health workers, essentially what we've seen is the importance of discharge planning be emphasized more at these facilities, and their how they do discharges has changed. It's better planned. There's more within team collaborative discussion around discharges, more inclusion of parents in the discharge process to ensure that they have safe transitions, and of course, better follow-up. This is just a very brief summary of that. There's a lot more details I can share if you want. And then finally, to sort of sum this up, I think it's important to mention that, and I think you understand this by now, that post-discharge care is a major barrier to achieving the 3rd SDG. Current guidelines do not address this important issue. Prediction modeling is key to a child-centered approach. This is sort of the precision public health approach. Prediction models have to be embedded into a larger health system-based approach. This can't just be sort of. I don't feel it's effective to just create an app and expect adoption. It has to be embedded into the system. We should create new guidelines, around post-discharge mortality. So it should be embedded into future sort of sepsis and severe illness, critical illness guidelines that outline, the basic care processes to improve discharge care. Essentially will hopefully improve this transition of vulnerable children to ensure that they have a full recovery at home. So that's the end of the slide. So I want to thank, of course, our partners and our donors. And we couldn't have done this without a whole lot of help from a whole lot of different people, a whole lot of groups. This is certainly not just my thing. This is I'm sort of representing it, but yeah. So that's basically it for that. And I'd love to open this up for discussion, questions. Yeah, thank you for being an attentive audience.
Thank you, Matt. I really appreciate it. I'll open up the floor to questions and maybe just kick things off with a question for you. You mentioned verbal autopsy, which, at least to my knowledge, isn't a concept that's come up during this lecture series. So I was wondering if you could just explain what that is, what that entails, and why you use that method.
Yeah. So one of the most common questions I get when I've done talks on this is, and I probably should have included a slide on that, is what are children dying from after discharge? And our initial studies we did back in 2011-12 didn't capture anything around the causes of death after discharge. And I think a common comment is also around, should these children just have been admitted for longer? Are they discharged too early? So in some sense, the issue around verbal autopsies was meant to sort of address that a little bit. So in this most recent study, we had about 365 deaths in whom we did a verbal autopsy. So we sort of looked at the various, the signs and symptoms that the parents observed prior to death. And we, and Teresa, you also helped on this. We sort of got, I think, 25 different pediatricians involved in looking at these verbal autopsy data. Each death was evaluated by 2 different physicians and then reconciled, just to sort of try to paint a picture of what are the causes of death after discharge. And what we essentially found was that the causes of death after discharge mimicked sort of the typical causes of death. So we saw pneumonia, malarial related illness, diarrheal illness, sort of general sort of sepsis, non-specific infection dominating the list. There was there was some non-infectious related illness in there, but primarily it was sort of these typical infections. So these are primarily preventable infectious illnesses that really led to death. And then another comment around timing is that more than half the deaths occurred more than 30 days after discharge. This is not just an issue around deaths occurring the day after or 3 days later that would have potentially been averted through a longer admission. These are deaths that are occurring weeks and sometimes months later. Yeah, I think that's probably a good summary. But next time I'll put a table of the VA data index. We do have some tables now done.
Yeah, that's really helpful. You actually answered a couple of my other questions as well, but essentially, so the verbal autopsy is interviewing the caregiver for signs and symptoms of cause of death. So it's a different system than what we typically do and what we would rely on if patients were primarily dying within the health system,
Yes.
right? Because there we would hopefully capture deaths and have a vital status registry like we do in this country that would have a death certificate with a cause of death. For the children who are dying at home, we don't have that.
Yes. So I guess to add to that, unlike in most developed countries, there is no vital statistics registration of deaths in places like Uganda or many other East African, Sub-Saharan African countries. So most of the cause of death information is related to causes of death for children who are admitted and die. And one of the questions is, are kids dying after discharge of a different set of circumstances? And I think the answer is generally no. It's more or less the same kinds of things. One thing we have to look at still is, are the causes of admission and discharge similar as the causes of death? And I think they line up often, but not always. There's definitely some exchanging. Kids who have admitted with pneumonia may die of malaria after. That definitely happens a bit.
Thanks, Matt. Duncan, you have your hand up.
Hey, Matthew. Thanks for your talk. I really enjoyed it. I had a question on the prediction model that you and your team created, and using the admission variables such as SpO2 and things like temperature, and whether you and your team had looked at variables closer to discharge and how those lined up in terms of predicting mortality.
Yeah, so we haven't done one with variables at discharge, partly well, there's a couple of reasons why. Number one, in Uganda, as in most places in these settings, there's a lot of children who end up leaving, who abscond from care. So in our studies, it was around like 12, 13%. That itself is a predictor of mortality. We do know that. But discharge tends to occur in a fairly rapid way. And we thought that using discharge predictors, of which we had it in fewer children and we have fewer variables, would not allow a sufficient amount of time to implement any sort of change in care. Having said that, we are looking at developing sort of a more dynamic model. So we have a master's student now who's working on this. Is we want to develop a model that is time dynamic. So we begin the process at admission. We sort of group children, and then there's an updating of that predicted risk based on some discharge characteristics. So once discharge is sort of planned, or we can capture some additional details and see if that can update the model. But currently, our model is 100% based on admission characteristics and doesn't account for anything at discharge. And partly, we just don't have tons of data. Like we have some data at discharge, but we don't have tons of discharge data compared to the admission data. And to be honest, we've looked at. Some data is independent of time. So, for example, HIV is not going to change over the course of discharge between admission and discharge. Some of them, of course, are time varying. So things like some of the vital parameters. But yeah, we haven't really looked at that in detail yet.
Thank you, Matt. I think we have maybe time for one more question if there's anything else from the audience, and also to say thank you. Tiffany has just dropped our link to the evaluation form in the chat. If you don't mind, just take a minute. It's very brief, couple of questions, but we do really value your feedback and change things year to year based on what we get back. Any final questions?
I had a question around the way the discharge counseling works. First, those pictorials look way better than what we have in the US in terms of, clear instructions to families about when to return to care. So I think there's a lot we could learn from some of that work. But in some of the places where I've worked clinically abroad, just that, ratio of whether it's nurse, clinician, community health worker to patient is so extreme that it feels really hard to provide a full conversation around discharge planning and discharge instructions. So you listed some statistics around the number of community health workers trained, but I'm curious what that looks like in any given facility around the ratio and the time that one is able to spend in some of that counseling.
Yeah, that's a really good point. And I should have mentioned there's a few other things that we've done. So one thing that we've done, because of the exact point you mentioned around, the burden of additional time spent counseling, is we've created sort of simple whiteboard drawing videos. So we had an artist put up the series, I think around like maybe 50 different images. And we've done a whiteboard like drawing, really like a slow reveal of the image. You've seen those before in various languages, counseling as a video format. So now we have this, and this in some facilities it's sort of like it cycles through on a screen. So some wards have like a television screen that has like various information, like healthcare information and advertising and other things. So we have the counseling cycling through on the ward to provide counseling, and then it's reinforced more quickly by the nurse. So that's one way to do it. I think we have a total of, I think, 8 or 9 videos on the different topics that we sort of focus on. With regards to the community health workers, so these are, so the community health workers in Uganda, at least, I think it's similar in other places, are community-based. They sort of represent sort of the community level of care. They're not really facility workers. They sort of are, in Uganda, they're volunteers actually, who have some very basic training on sort of ICCM, integrated community case management, which is like basic pediatric health, and then some healthcare counseling and hygiene and all that kind of stuff. So they've been now trained on when a child comes home after being discharged, they are vulnerable, they need to be seen. These are the things that you look for. So usually each village has like 2 or 3 of those individuals. And they do a variety of things. They may do some well baby checks sometimes, but they're now being trained. So there's literally in Uganda probably like 100,000 community health workers. So we've done, touched a very small proportion of them. But nonetheless, we're trying to capture this issue both from the facility level and from the community level. But I agree with you 100%. Health workers are overburdened, and just adding more tasks to the list is not necessarily ideal. So trying to ease that with technology, and that's where the videos come in.
Thanks, Matt. I was wrong. We have time for a few additional questions.
Matthew, I had one other follow-up question to ask. That's meta-analysis that you're doing showing percentage of those that die in hospital versus post-hospital. Anemia was one that had a lot more post-hospital deaths, and kind of what your general thought were behind that. Is it, we know some children that come in will get transfused if they come in with a low hemoglobin, but what are your thoughts about why specifically anemia has such a high post-discharge mortality compared to other conditions?
Yeah, that's a really interesting question. We're trying to explore that a little bit in our data, in our own data. One thing we've observed when we look at the median or the average time to death is higher in anemic kids than in non-anemic kids. So there's a more persistent risk in anemics versus in non-anemics, more than we see in malnutrition. So malnutrition may have a higher burden of deaths overall, but their persistent risk over time seems to diminish more. But if you look at the hazard curve of anemics, that curve does not really plateau very quickly. It stays high. So much so that an anemic child dies on average 37 days later than a non-anemic child if they're going to die. So we looked at 370 deaths, and the deaths in those with severe anemia was literally 37 days later than in those who died who did not have anemia. So there's an issue around persistence of risk, and I think that explains in part why that red bar is longer during the post-discharge period.
And you have data as to whether they got transfused or not in hospital, right?
Yeah, so we haven't looked at it. So we do have data. I know that there's transfusion it's a complicated issue because some hospitals, they run out of blood, and it's not, we can't look at transfusion as necessarily a risk factor, because there's lots of kids who needed to get transfused who didn't, and we don't really know who those kids are. And we can make a criteria. We certainly have the results, like we know the hemoglobin results, whether or not it was in the presence of a transfusion or not, and we know if they did get transfused, but we haven't really examined that in detail yet.
Okay. Any other questions from the group? I see Martina's on as well. Anything to add, Martina? I'm sorry, for those who don't know, Martina's actually analyzing a lot of the data that went into the verbal autopsy project.
She's one of the superstars of the verbal autopsy project.
Oh.
Wrangling like 25 physicians. That's not an easy task.
Okay, thanks, Martina. Yeah, I know that's the hardest thing, right? It's trying to get physicians of all directions. Okay. All right. Well, with that, then why don't we close the session? Thanks so much, Matt. It was really interesting to hear the work that you're doing. And I think I'll follow up with you by email. We've had a couple other presenters in this lecture series who are also doing some algorithm and app development that it might be interesting to connect with them.
Yeah, it's great.